Imagine sitting in a doctor's office, right? You feel like completely fine. You run 5 miles a day, you sleep 8 hours a night, you eat your greens.
Yeah, you're the absolute picture of health.
Exactly. But the doctor just slides a piece of paper across the desk and says, "You have cancer."
Which is terrifying.
Right. And then before you can even process the panic, the doctor looks you dead in the eye and says, "And the absolute worst thing we could do right now is try to cure it."
It just completely breaks your brain. It goes against everything we think we know.
It really does. Welcome to the iMedix podcast. Today, we're looking at a question that sounds simple, but is surprisingly difficult. Which early screening tests actually help?
Because it's a huge medical puzzle, honestly.
Yeah, we are constantly bombarded with this message that early detection is everything. I mean, it's on billboards, it's in our social media feeds, it's just baked into our psychology.
Catch it early, save your life.
Exactly. So the central question for this deep dive is this. If early detection unequivocally saves lives, why doesn't the medical community recommend testing everyone for every possible disease as early as humanly possible?
It's kind of the ultimate paradox in modern preventive medicine.
Right.
And our mission today is to navigate this incredibly fraught space between, the profound hope of early diagnosis and the very real, often hidden harms. Things like false positives, overdiagnosis, and just crippling medical anxiety.
Because it's not always a net positive.
Exactly. We are going to look strictly at where the evidence stands in 2026, because we need to create a roadmap for you, the listener, to understand the critical difference between fear-driven testing, which is like everywhere right now, and actual outcome-improving medical strategy.
Okay, let's unpack this, because the reason we have to do that is due to a massive psychological hurdle. Human intuition tells us that more information is always better, right?
Always.
If a tumor is growing, or, I don't know, if plaque is building up in my brain, I want to know about it yesterday.
Oh, absolutely. But in medicine, the concept of catch it early isn't a universal good. It's highly conditional.
Which feels wrong to even say out loud.
I know it does. But to understand why, we first have to draw a hard, thick line between two concepts that people use interchangeably, but they represent entirely different universes of medicine.
And those are...
Diagnostic testing versus screening.
Okay, diagnostic versus screening. Let's break that down.
This distinction is the bedrock of everything we're going to discuss. Let's look at the biology of a diagnostic test first. A diagnostic test is what happens when you already have physical symptoms.
Like your body is waving a red flag.
Exactly. Let's say you go to your doctor with a persistent, hacking cough that just won't go away, and you're coughing up blood.
Definitely a red flag.
Right. Biologically, something is actively irritating the cilia in your respiratory tract, triggering an inflammatory response and rupturing microvessels in your lungs. So the doctor orders a chest CT scan to find the source.
And that is diagnostic.
That is diagnostic. You are investigating a specific, active physiological problem that has already announced its presence.
So what's screening then?
Screening, on the other hand, is testing an asymptomatic, seemingly perfectly healthy population. You feel fine, no cough, no pain. Your biological alarms are totally silent.
You're just taking a test to go hunting for hidden microscopic disease.
Yes, exactly.
So because you are starting with a healthy person, the ethical and mathematical burden of proof for that screening test has to be, like, exponentially higher.
Immensely higher. It is a completely different medical philosophy based on the ancient Hippocratic principle first, do no harm.
Right, because if you're already sick, the risk changes.
Exactly. When you have symptoms, you are already sick. The biological damage is underway, and the goal is to figure out why so we can stop it.
So the risks of the test itself are kind of justified.
Yeah, the inherent physical risk of the testing, like the radiation of a scan or the risk of a biopsy, they're justified by the immediate need to solve an active threat.
But with screening, you are dealing with healthy people.
Right. If you are going to intervene in the life of a healthy person, you have to be absolutely certain that the intervention brings a net positive benefit.
It's not enough just to find something?
No. It is not enough for a screening test to simply find an anomaly. The medical community requires rigorous proof that finding it early actually improves meaningful clinical outcomes.
Meaning what?
Specifically, does catching this microscopic disease early extend your overall survival? Or does it significantly improve your quality of life compared to if we had just waited for the symptom to appear?
Which, again, feels completely counterintuitive. I can hear people yelling at their speakers right now like, of course, catching a tumor early extends survival. It's smaller.
I know.
Let's use an analogy to look at this systemic problem. Think of a screening program like airport security. You have thousands of people walking through the doors who seem perfectly fine, right?
Right, they are your asymptomatic population.
Yeah. And if you decide to screen absolutely everyone with the most intense, hypersensitive, molecular level machinery possible, what happens?
You find everything.
You are going to pull aside every single person who has, like, a slightly oversized bottle of shampoo, a weirdly shaped belt buckle, or a forgotten tube of toothpaste.
You find a lot of anomalies, sure, but those anomalies are harmless.
Exactly. The result of that hyperscreening is massive systemic delay, huge panic, missed flights, and traumatized travelers, all to find a whole lot of nothing.
And diagnostic testing, on the other hand, is like the police questioning a specific suspect because they were literally seen holding a weapon at the scene of a crime.
You have a highly specific reason to look.
That analogy holds up beautifully when you map it onto human biology. When you screen everyone for everything, you are forcing the medical system to pull out every bottle of shampoo in the human body.
And that's not just a quick pat-down.
No. The problem is, in medicine, investigating those harmless biological anomalies involves needles, radiation, scalpels, and general anesthesia.
Wow, yeah. And there is another side to this intuition trap, too, which is the danger of false reassurance.
Oh, this is so important. Let's look at a real-world scenario. Imagine a patient. Let's call him David.
Okay, David.
David has been feeling incredibly fatigued. He has persistent deep abdominal pain, and he's losing weight rapidly.
Sounds like he needs a diagnostic test.
Right. But he just got his annual screening blood work back, like a standard metabolic panel, and a complete blood count. And his doctor says, great news, your blood work is completely normal.
So David goes home and thinks, awesome, I'm healthy. The abdominal pain must just be stress or indigestion.
And that biological assumption is incredibly dangerous. We have to look at what those tests actually measure.
Because they aren't looking for everything.
Not at all. A complete blood count is looking at the sheer volume of red blood cells, white blood cells, and platelets. A metabolic panel is looking at broad markers like sodium, potassium, basic kidney, and liver function.
Just the basics, really.
Yeah, these are macroscopic views of systemic homeostasis. They are not looking for the specific mutated proteins shed by early-stage pancreatic cancer, nor do they measure the motor neuron degradation of early-stage ALS.
Right.
Pancreatic cancer, for instance, often does not alter basic blood production until it is in its absolute most advanced metastatic stages.
So if David ignores his persistent, localized physical symptoms because a generalized screening test told him he was normal, he is falling victim to false reassurance.
Exactly. A screening test is a wide, porous net.
Yeah.
If you have symptoms, you need targeted diagnostic testing, regardless of what a broad screening panel says.
So to really grasp why more information isn't always the blessing we think it is, we have to look under the hood of the math.
We really do.
We need to understand the statistical reality of how these tests actually function in large populations. Because a medical test is not a perfect, all-seeing crystal ball.
No, it is an exercise in probability.
Which brings us to the Dictionary of Doubt.
The Dictionary of Doubt. I love that term.
Yeah, it's a perfect term because the language we use around medical testing often implies a binary certainty, like you either have it or you don't, where biologically there is mostly gray area.
So much gray area. When epidemiologists evaluate how good a screening test is, they look at two fundamental metrics: sensitivity and specificity.
Right, and from those metrics, we get the real-world consequences: false positives, false negatives, and the most complex biological phenomenon of all, overdiagnosis.
Let's ground sensitivity and specificity in something we all understand. Let's take your smoke detector analogy, but we're going to expand it to show how crazy this gets in the human body.
Okay, let's do it.
Sensitivity is about how easily the alarm gets triggered. A highly sensitive smoke detector is the one that goes off every single time you burn a piece of toast in the kitchen.
Ugh, I have one of those. It's so annoying.
Right. It is incredibly obnoxiously good at detecting smoke. It will absolutely not miss a real house fire. That means it has a very low rate of false negatives.
But the downside of that extreme sensitivity is that it screams at you when there is no actual danger. The alarm says lethal fire, but the reality is just a burnt bagel.
Exactly. That is your false positive.
Okay, now flip it to specificity.
Price specificity means the detector only goes off for a legitimate 2,000-degree raging house fire.
It doesn't care about your burnt toast.
Right. It completely ignores a blown-out candle or a smoky fireplace. It is highly specific to a lethal crisis.
But the biological problem there is if a medical test is too specific, it might ignore a smoldering fire in the wall.
Yes, a slow-growing but dangerous tumor. It ignores it until it breaks through the drywall and it's too late. That's a false negative.
So the holy grail of screening is a perfect balance. We want to catch all the lethal house fires without calling the fire department every time someone makes toast.
But here is the mathematical truth of 2026. No test in existence is 100% sensitive and 100% specific. There is an inescapable mathematical trade-off.
And to really understand why a false positive is so devastating, we have to look at the math of Bayes' theorem.
Yes, the Bayes' theorem trap.
Because this is the ultimate aha moment that made me realize why doctors don't just screen everyone for rare diseases. If you have a test that is 99% accurate, meaning it has 99% sensitivity and 99% specificity...
That sounds amazing, right?
That sounds perfect.
But if you apply that 99% accurate test to a rare disease that only affects 1 in 1,000 people, the math gets terrifying.
Let's walk through that exact calculation for the listener because it is the most counterintuitive math in medicine.
Let's go.
Imagine a population of 100,000 people. You said the disease affects 1 in 1,000. So out of that 100,000, exactly 100 people actually have the hidden disease.
Okay.
And 99,900 people are perfectly healthy.
So we run our 99% accurate test on absolutely everyone?
Right. First, it finds the sick people. Since it is 99% sensitive, it correctly identifies 99 out of the 100 sick people. Great.
Great. But now we have to run that same test on the 99,900 perfectly healthy people.
Because the test is 99% specific, it correctly tells 98,901 of them that they are healthy.
But it gets 1% of them wrong.
Yes. 1% of 99,900 is 999. Whoa, wait, so the test just handed out 999 false positives.
Exactly. So in total, the test flagged 1,098 people as positive for disease, but only 99 of them actually have it.
The other 999 are completely healthy.
This means if you are a patient in this population and you get a positive result on a 99% accurate test, your actual chance of having the disease, your positive predictive value, is only about 9%.
That is mind-blowing.
There is a 91% chance you are perfectly fine, yet you are now in the medical system, terrified, preparing for biopsies and agonizing treatments.
This is the mathematical trap of screening low-risk populations.
It really is.
A 99% accurate test still means you probably don't have the disease if it flags you. But as terrifying as a false positive is, you mentioned a concept earlier that is actually way more insidious, overdiagnosis.
What's fascinating here is a false positive is a mathematical mistake.
The test thought a biological shadow was a tumor, but it was just benign tissue.
Right. Overdiagnosis is not a mistake. It is the flawless execution of a test finding a real anomaly.
Wait, hold on. This is where you lose me and where you lose the patient.
I know, it's hard to wrap your head around.
If the test found a real, genetically mutated tumor inside my body, how is that a bad thing? If you tell me I have a tumor, my brain instantly goes into survival mode.
Of course it does.
You're telling me I should just walk around knowing a tumor is inside my neck and do nothing. How does a doctor even convince a patient that finding a real tumor is a problem?
It is the hardest conversation in medicine. And to understand it, we have to look at the cellular biology of cancer.
Okay, explain that to me.
We have been socially conditioned to view all cancer as an unstoppable, speeding train that starts as one cell, divides relentlessly, and will inevitably metastasize and kill you if you don't eradicate it.
That's definitely how I picture it.
But molecular biology tells a very different story. Cancers are not all speeding trains. Some cancers are like turtles.
Turtles.
Yes, they are real microscopic malignancies with mutated DNA. But they grow so incredibly slowly that they would never, ever cause a symptom, and they would never shorten your natural lifespan.
Wait, really? Why are they so slow? What makes a cancer a turtle?
Several biological factors. First, telomere length. Telomeres are the protective caps on the ends of our chromosomes.
Right.
Every time a cell divides, the telomeres get shorter. When they get too short, the cell enters a state called senescence. It essentially falls asleep and stops dividing.
Oh, I see.
Many turtle cancers reach senescence naturally and just sit there for decades. Second is the immune system. We all have microscopic cancers forming in our bodies constantly.
Which is terrifying to think about, but okay.
But our immune system, specifically our T cells, act as biological bouncers. They recognize the mutated proteins on the surface of these turtle cells and keep them in check.
So they wall them off.
They wall them off in a microenvironment where the tumor's technically alive, but utterly dormant. If we never scanned you, you would eventually die with this tumor, not of it. Perhaps at age 90 from a heart attack.
So overdiagnosis is finding the turtle.
Overdiagnosis is finding the turtle, because once you find it, human psychology and medical liability take over.
The label of cancer has been applied.
And treating a turtle causes profound, unnecessary harm. Let's look at the classic cascade of interventions.
Let's hear it.
Imagine a healthy, asymptomatic 45-year-old woman. She reads a lot of health blogs, she's anxious, and she decides to pay out of pocket for a hypersensitive full-body MRI scan.
I see ads for these everywhere. Take control of your health. Don't leave it to chance.
Right, so she gets the scan. The MRI is incredibly powerful. It slices her body into millimeter-thin digital cross-sections, and it finds a tiny 3-millimeter nodule on her thyroid gland.
Okay, so they found something.
But autopsy studies on people who died in car accidents show us that a massive percentage of the adult population walks around with tiny, indolent thyroid nodules that they never knew they had.
They are classic turtles.
Exactly. But now, this woman knows about it. Her peace of mind evaporates instantly.
And the doctor can't just look at the MRI and say, oh, that's just a turtle, go home.
They legally can't. The radiologist's report will inevitably read, cannot rule out malignancy, clinical correlation recommended.
So defensive medicine kicks in.
She goes to an endocrinologist. The endocrinologist orders a fine needle aspiration biopsy. A needle is physically guided into her neck to extract cells.
Which sounds awful.
Let's say the biopsy cytology is indeterminate. It looks slightly atypical but not definitive. Because of the anxiety, they recommend surgery to remove half of her thyroid, just to be safe. She undergoes general anesthesia, which carries its own systemic risks of cardiovascular complications or allergic reactions. She has the surgery. A week later, the pathology report comes back on the removed tissue. It was a microscopic, ultra-slow-growing papillary microcarcinoma.
A turtle.
A turtle.
But she had to have part of an organ removed, and now she might have to take synthetic thyroid hormone pills every day for the rest of her life because her endocrine system is permanently compromised.
Yes. And socially, she will consider herself a cancer survivor. She will tell her friends that the full-body scan literally saved her life.
When the reality is...
The epidemiological reality is that the scan did the exact opposite. It ruined her psychological peace, subjected her to surgical and anesthetic risks, and turned a healthy woman into a lifelong patient, all to eradicate a cluster of senescent cells that never would have harmed her.
That reframes the entire concept of health. The test that was marketed to relieve her anxiety became the exact instrument that destroyed her physical and psychological well-being.
This is why population-level screening must clear that incredibly high biological bar. We have to mathematically prove that the lethal house fires we catch massively outweigh the harmless turtles we unnecessarily mutilate.
Okay, so knowing this minefield, the Bayes' theorem traps, the false reassurance, the biology of turtles, we have to look at the tests that do have strong, undeniable, outcome-improving evidence behind them.
Because the medical community isn't anti-screening. They are relentlessly pro-evidence.
Right. Let's look at the heavy hitters, the cancer screenings that actually work and are aggressively recommended by major health task forces: cervical, colorectal, lung, breast, and prostate.
Yes. And it is vital to understand that not all of these heavy hitters operate on the same biological principles.
How so?
The absolute gold standards of the screening world, the ones that offer the cleanest, most undeniable mathematical benefit, are cervical cancer screening and colorectal cancer screening.
And the reason they are the gold standards is because they do something practically magical, right?
They do. They don't just catch early invasive cancer. They literally prevent the cancer from ever existing.
Because they are hunting for precancers. Explain the biology of how that works.
Let's start with cervical screening. The vast majority of cervical cancer is caused by the human papillomavirus, or HPV.
Right.
Biologically, HPV is a virus that infects the epithelial cells of the cervix. When it integrates its viral DNA into the host cell's DNA, it produces two viral proteins called E6 and E7.
What do those do?
These proteins act like saboteurs. They bind to and disable the human cell's natural tumor suppressor genes, specifically P53 and ARB.
Ah, okay.
Without those suppressors, the cervical cells start dividing abnormally, creating cellular dysplasia. This takes years, sometimes a decade.
And that's where the pap smear comes in.
Exactly. During a pap smear, a clinician physically scrapes the surface of the cervix to collect these cells. A cytopathologist looks them under a microscope.
And if they find them early?
If they see those early dysplastic abnormal cells, before they have gained the ability to invade deeper tissues, a doctor can simply freeze them off with cryotherapy or remove them in a 15-minute outpatient procedure.
Wow.
The viral saboteurs are destroyed, and the cancer is literally stopped before it ever forms.
And the exact same biological prevention applies to colorectal screening, like colonoscopies.
Yes, very similar concept.
Right. With a colonoscopy, the doctor is navigating a camera through the large intestine looking for polyps. Explain what a polyp actually is.
A polyp is a macroscopic clump of cells growing on the inner lining of the colon. Biologically, this process is known as the adenoma-carcinoma sequence,
Okay, so it starts benign.
usually with an inherited or acquired mutation in a tumor suppressor gene called APC. This allows a small benign growth to form.
A polyp.
Over the next 10 to 15 years, this benign adenoma accumulates more genetic mutations, like in the KRAS oncogene or the P53 gene. Slowly, it transforms from a harmless bump into an aggressive, invasive adenocarcinoma.
But the colonoscopy interrupts that 15-year timeline.
Precisely. The doctor sees the adenomatous polyp on the camera screen, loops a wire snare around it, cauterizes it, and removes it from the body right then and there. Boom.
The genetic timeline is severed.
That polyp can never, ever become cancer. It is profound prevention masquerading as screening.
Okay, so let's contrast those preventive miracles with lung cancer screening, which relies on a completely different logic.
Very different logic. Lung cancer screening is incredibly effective, but it is highly, highly targeted. We absolutely do not screen the general population for lung cancer.
But why not? Lung cancer is the leading cause of cancer death globally. If we have a machine that can see it, shouldn't we scan every 50-year-old's chest?
Because of the biological reality of the lungs and the false positive rate of the imaging tool we use, which is the low-dose CT scan.
What's wrong with scanning the lungs?
Think about what your lungs do. They are the body's filter for the outside world. Over decades, you inhale dust, pollution, and you fight off minor respiratory infections.
Right, they take a beating.
The lungs heal these insults by forming tiny scars, calcifications, and localized areas of fibrosis.
And on a scan.
To a highly sensitive CT scan, a benign scar from a bout of pneumonia you had in 1998 looks remarkably similar to an early-stage malignant nodule. They are both dense spots on the film.
So if you scan everyone, you're going to find millions of spots.
Tens of millions. You will find endless bottles of shampoo. And investigating a spot in the lung is not like snipping a polyp in the colon.
How do they biopsy a lung?
It often requires a transthoracic needle biopsy, pushing a needle through the chest wall into the lung tissue. This carries a significant risk of pneumothorax or collapsing the lung.
Oh, wow.
If you scan the general population, you will collapse thousands of healthy lungs to biopsy ancient harmless scars.
But if you apply that exact same CT scan to a mathematically defined high-risk groups, say people aged 50 to 80 who have a 20-pack-year smoking history, the Bayes theorem math flips entirely.
Exactly, because the pretest probability changes.
Explain that.
In a heavy smoker, the statistical probability that a dense spot on the CT scan is a lethal, fast-moving malignancy driven by the carcinogens in tobacco smoke is exponentially higher.
So the math makes sense now.
The sheer mathematical benefit of finding a lethal lung cancer early in this group vastly outweighs the risk of the false positives and the biopsies. Patient selection based on clinical risk is the only thing that makes lung screening viable.
Okay, so cervical and colon are about interrupting the cellular timeline to prevent cancer. Lung is about highly targeted, risk-based detection. But then we get to breast and prostate screening.
Right.
And this is where the biological math gets incredibly muddy and where the debates in the medical community get practically tribal.
They really do. Let's drill down into prostate screening, specifically the PSA blood test prostate-specific antigen.
I hear about this one a lot.
To understand the controversy, we have to understand the biology of the prostate gland itself. The prostate's primary job is to secrete a fluid that nourishes and protects sperm. PSA is a biological enzyme, a protease produced by the prostate to liquefy semen so sperm can swim. It is supposed to stay contained within the prostate ductal system.
But sometimes it gets out.
But when the prostate architecture is disrupted, PSA leaks into the bloodstream where we can measure it.
But cancer isn't the only thing that disrupts that architecture, right?
Not even close.
No.
As men age, the prostate naturally enlarges a condition called benign prostatic hyperplasia, or BPH.
And that causes a leak?
That enlargement stretches the tissue and leaks PSA. A minor urinary tract infection causes inflammation, which leaks PSA. Even riding a bicycle for a long distance can physically massage the prostate and cause PSA to leak into the blood.
Wait, really? So the PSA test is incredibly sensitive to prostate disruption, but it has terrible specificity for cancer.
Exactly. And even if it is cancer, we run into the turtle problem again.
Oh, right. The slow growers.
The prostate is the undisputed biological king of the turtles. Pathological studies on men in their 80s who died of completely unrelated causes show that up to 70% of them have microscopic prostate cancer.
70%.
Yes. The vast majority of prostate cancers are so slow-growing they will never breach the capsule of the gland, let alone metastasize.
But historically, we treated the PSA test like a binary cancer alarm, right?
Millions of men with elevated PSA levels due to benign enlargement or indolent turtles underwent biopsies. And when the biopsy found those harmless turtles, they underwent radical prostatectomies, surgical removal of the entire gland or aggressive radiation.
Curing a disease that wasn't going to kill them, but leaving them with the collateral damage of the cure.
Severe collateral damage. Radical treatment of the prostate frequently damages the delicate neurovascular bundles surrounding the gland, leading to permanent urinary incontinence and erectile dysfunction.
So we were subjecting millions of men to life-altering morbidity to eradicate turtles.
Yes. This is why modern prostate screening guidelines have shifted away from blanket testing and toward shared decision-making.
Where the doctor has to explain the immense risk of overdiagnosis to the patient before they ever draw the blood.
Precise.
So what does this all mean for me if my parents were sick? Does this whole playbook change? Because suddenly, biologically, I don't feel like I'm part of the general population.
That is a crucial distinction. Yes, the playbook fundamentally changes. Inherited genetic risk alters the entire mathematical equation of screening.
Okay, so how does that work?
We talked earlier about tumor suppressor genes. If you have a known genetic mutation in your family, say a BRCA1 or BRCA2 mutation for breast and ovarian cancer, you are operating with a different biological baseline.
Explain what BRCA actually does, because people just think of it as the breast cancer gene.
Right, which is a misnomer. BRCA genes are actually your body's heavy-duty repair mechanics. Biologically, they're responsible for homologous recombination. They repair double-strand breaks in your DNA.
Breaks from what?
Every day, your DNA gets damaged by UV light, cellular metabolism, toxins. If you have normal BRCA genes, they perfectly repair that damage.
Even if they're mutated.
If you inherit a mutated, broken BRCA gene, your cells cannot repair their DNA effectively. Mutations rapidly pile up, drastically accelerating the timeline for a normal cell to become a malignant tumor.
So if you carry this mutation, or if you have a strong family history, like a first-degree relative with early onset disease, you are moved out of the general population screening category.
And into a high-risk surveillance category.
Let's walk through a real-world scenario. A listener's dad had colon cancer at 45. Standard guidelines say start colonoscopies at age 45. Should this listener wait until they are 45?
Absolutely not. The epidemiological rule of thumb for a first-degree family history of colon cancer is to begin screening 10 years before the age your relative was diagnosed, or at age 40, whichever is earlier.
So for this listener, they should be getting their first colonoscopy at age 35.
Because their presumed genetic predisposition means their pretest probability, the likelihood that they are already growing a dangerous adenomatous polyp is significantly higher than an average person.
The risk-benefit math shifts aggressively to favor earlier, more invasive, and more frequent testing.
Family history is the ultimate modifier of the Bayes theorem equation.
It's like living in a neighborhood where the houses are literally built with flammable materials. You want the smoke detector installed earlier, and you will absolutely tolerate a few more false alarms just to be safe.
That's a perfect way to put it.
Okay, so we've established the biological rules for these organ-specific tests. The heavy hitters, they look at specific anatomy, the colon, the cervix, the breast, the lung.
Right.
But we are sitting here in 2026. The technology is moving at light speed, moving away from localized imaging and towards systemic genomics. What about the new wave of tech that promises to look for everything all at once?
Yes, we are entering what many epidemiologists are calling the Wild West of medical technology. And at the absolute forefront of this frontier are MCEDs.
Multi-cancer early detection blood tests. Here's where it gets really interesting, because the marketing for this is mesmerizing. It feels like the ultimate frictionless biohack. You're telling me I don't need a colon prep, I don't need to be shoved into a loud claustrophobic MRI tube.
Just a blood draw.
Yeah, I can just walk into a boutique clinic, give 2 vials of blood, and an algorithm will tell me if I have any of 50 different types of cancer anywhere in my entire body. Sign me up.
And that is exactly how they are being positioned by direct-to-consumer biotech companies. It exploits the intuition trap perfectly. But to understand why the medical oncology community is urging extreme caution, we have to explain the profound molecular biology of what these MCEDs are actually trying to do.
What are they looking for?
They are hunting for something called ctDNA, circulating tumor DNA,
Let's break that down. How does tumor DNA get into my bloodstream?
through cellular death. In a healthy body, millions of normal cells die every day through a highly controlled programmed process called apoptosis.
So it's a clean process.
It's clean. Cellular garbage collectors called macrophages eat the dying cell, and the DNA is neatly recycled. But tumors are chaotic.
How so?
As a tumor rapidly outgrows its blood supply, many of its cells die through a messy process called necrosis. When tumor cells burst open and die, they spill their mutated genetic contents, their DNA, directly into the surrounding capillaries, washing into the bloodstream.
So the idea behind an MCED is that if you have a hidden cancer somewhere, say a tiny lesion in your ovary or your pancreas, that tumor is constantly shedding fragments of its mutated DNA into your blood.
Exactly.
But my blood is full of normal, healthy DNA from normal cells turning over. How does the machine tell the difference between normal garbage and tumor garbage?
That is where the 2026 technology is breathtaking. It is a marvel of epigenetics and machine learning. The sequencing machines don't just look for genetic mutations, they look at methylation patterns.
What are those?
Methyl groups are chemical tags on DNA that turn genes on or off. Cancer cells have radically distinct chaotic methylation patterns compared to healthy cells.
Okay, that makes sense.
The machines also look at fragmentomics tumor. DNA tends to be chopped up into specific, predictable fragment lengths compared to healthy DNA.
Oh, wow.
The algorithm analyzes millions of these fragments to find the needle in the haystack, the unique epigenetic signature of a cancer cell.
That sounds like science fiction, but it's real. The technology can isolate these fragments. So why is the medical community hesitant?
Because we must fiercely separate technological capability from clinical utility. Just because a machine can detect a microscopic fragment of aberrantly methylated DNA does not mean that acting on that molecular information will save your life. Let's go back to our smoke detector analogy. Trying to find early-stage localized cancer using a blood test is like standing in New Jersey sniffing the air and trying to detect a specific wastebasket fire inside an apartment building in Manhattan.
That's a long distance.
Right, to catch it, you have to turn the sensitivity of your nose up so high that you end up smelling a barbecue in Brooklyn and calling in the fire department.
Let's walk through the worst-case clinical scenario of this sensitivity. Let's imagine a perfectly healthy patient. Let's call her Sarah.
Okay.
She's 50, feels great, but buys one of these direct-to-consumer MCED panels online for $1,000. She sends in her blood, and 2 weeks later, she gets an alert on her phone. The screen is flashing red. The test result says, positive for cancer signal detected.
This is the exact clinical nightmare oncologists are terrified of. Sarah is thrust into an acute state of psychological trauma. She rushes to her primary care doctor.
But they don't know where it is.
Right. The blood test says cancer signal detected, but the crucial flaw in many of these tests is that they cannot always tell you exactly where the cancer is located.
Right.
It is a cancer of unknown primary.
So the doctor has to start a systemic anatomical hunt based on a molecular whisper?
Yes, so they start doing all the organ-specific tests we talked about earlier. But in a panic, Sarah gets a high-resolution chest CT. It's clear.
Okay.
She gets a contrast MRI of her abdomen and pelvis, looking at her liver, pancreas, ovaries.
No.
Clear. She gets an MRI of her brain. Clear.
Wait.
She undergoes an upper endoscopy and a colonoscopy.
Yeah.
Clear. She has her thyroid ultrasounded. Clear.
Wait. She has spent tens of thousands of dollars on advanced imaging. She's been injected with contrast dyes. She's been irradiated. She's terrified. And the physical scans cannot find a tumor anywhere in her body.
Correct. Because imaging technology has physical limitations. An MRI usually can't reliably resolve a tumor smaller than a few millimeters.
But the molecular test can.
But the molecular blood test might be detecting the DNA shedding of a tumor that is only a half millimeter wide. So now, Sarah is trapped in medical purgatory.
The blood test swore she has cancer, but the billion-dollar imaging machines can't find it. So what does she do? Just wait.
That's all she can do. Is the tumor just too small to see yet, and she needs to come back for full-body radiation scans every 6 months until it grows large enough to be targeted.
Or what if it's a false positive?
Or, and this brings us back to the Bayes theorem math,
Yeah.
with a blood test of false positive caused by some benign inflammatory condition that confused the algorithm.
Or the turtles.
Or, worst of all, did the blood test detect a tiny indolent turtle of a cancer that is actively shedding DNA but will never ever grow large enough to cause a physical problem?
Oh my God.
Sarah will live every single day for the rest of her life waiting for the other shoe to drop. The profound psychological anxiety of this diagnostic limbo perfectly illustrates why a clinician must explain that a test can detect something at a microscopic, molecular level without necessarily improving your survival.
Sometimes, shining a hyper-bright spotlight into the microscopic corners of human biology only reveals molecular ghosts that terrify us without offering any actionable cure.
Exactly.
That is incredibly heavy. It really forces you to reconsider what we mean by knowing. We are creating a generation of patients who are biologically healthy but psychologically terminal.
It's a very real danger.
But if cancer screening is this complicated, tangled up in the biology of turtles and the anxiety of molecular ghosts, screening for cognitive decline introduces an entirely new, almost philosophical layer of complexity.
It really does.
Because cancer is, at its core, about abnormal cells physically multiplying. You can point to a mass on a scan, you can biopsy it, you can sequence it, but the brain? Dementia, that's a totally different beast.
It is fundamentally biologically different. When you are screening for cancer, you are looking for a physical, anomalous entity, a polyp, a malignant cellular clone. You can put it on a slide and say, yes, this cell's architecture is malignant.
But with dementia, what are we actually looking for?
We were looking at the fading of cognition. We are evaluating memory, executive function, personality changes, language processing.
And cognition is not a single biopsyable thing.
No, it is an emergent property of billions of neurons communicating across vast synaptic networks. It is highly subjective, highly variable from person to person, and incredibly difficult to measure with binary precision.
Right. If I forget where I put my car keys or if I struggle to remember a coworker's name, is that early stage Alzheimer's destroying my temporal lobe, or am I just chronically sleep deprived because I have a toddler? It's not like a jagged white line on an x-ray showing a broken arm. So how does the medical community even attempt to evaluate this network degradation in 2026? What does the dementia diagnostic toolkit look like?
The toolkit is multifaceted precisely because no single tool can measure the entire network. Historically, and still fundamentally, we rely on functional cognitive assessments.
Like questionnaires.
Yes, these are standardized point-based questionnaires like the MoCA, the Montreal Cognitive Assessment, or the MMSE.
What do those actually test, biologically speaking?
They test specific lobes of the brain by asking you to perform tasks. When the doctor asks a patient to draw a clock face and set the time to 10 past 11, they aren't just testing time telling.
What are they testing?
They are testing the parietal lobe, which handles visual spatial relationships, and the frontal lobe, which handles executive function and planning.
Oh, that's fascinating.
When they ask you to recall a list of 5 words 5 minutes later, they're directly testing the short-term memory encoding function of the hippocampus. These test actual, real-world functional ability.
Okay, so that's the functional test. But what about looking at the physical brain itself?
Then we move to neuroimaging. A structural MRI can look at the physical architecture of the brain. We look specifically for cortical thinning and hippocampal atrophy.
Like, is the memory center physically shrinking?
Right, shrinking at a rate faster than expected for the patient's age. But an MRI just shows structure. To see the specific pathology of Alzheimer's, we use PET scans.
Explain the biology of the PT scan, because this is where the specific Alzheimer's proteins come into play.
In Alzheimer's disease, a specific sticky protein called beta amyloid misfolds and clumps together to form hard plaques between the neurons in the brain.
And those plaques disrupt the signals.
Exactly, they disrupt synaptic communication. An amyloid PT scan involves injecting the patient with a specialized radioactive tracer that crosses the blood-brain barrier and binds specifically to these amyloid plaques.
So you can actually see them.
When you put the patient in the scanner, those plaques light up, showing us the exact pathological burden in the brain. We also look at genetic risk markers, most notably the APOE gene.
Right, APOE4. I hear about this all the time in longevity circles. What does that gene actually do?
The APOE gene provides instructions for making a protein that transports cholesterol and other fats in the bloodstream and the brain.
Okay.
In the brain, specialized support cells called astrocytes use APOE to carry lipids to neurons to help repair them. But the APOE protein is also involved in clearing out that sticky beta amyloid garbage we just talked about.
So it's a cleaner.
We all inherit 2 copies of the APOE gene. If you inherit the E4 variant APOE4, that version of the protein is fundamentally defective at clearing out the amyloid garbage.
Ah, so the plaques build up faster.
Yes. If you carry 2 copies of the APOE4 gene, your statistical risk of developing Alzheimer's is dramatically elevated compared to the general population.
Okay, let's unpack this toolkit. Because with a cancer biopsy, if the pathologist sees the mutated cells under a microscope, it's definitive. You have cancer.
Right.
But with dementia, isn't it true that you can have the biological markers of the disease in your brain? Like you carry the APOE4 gene and your PET scan is lighting up like a Christmas tree with amyloid plaques, but you still function perfectly well.
It is true.
You're still doing the Sunday crossword, driving your car, paying your taxes.
This raises an important question, and it is the central, mind-bending paradox of Alzheimer's research. The presence of biological pathology does not reliably equal clinical dementia.
How do we know that?
Extensive autopsy studies, like the famous Nun study, have shown us that many elderly people die with brains completely riddled with amyloid plaques and tau tangles, the undeniable biological hallmarks of Alzheimer's disease.
But they were fine.
During their lives, they never exhibited a single symptom of cognitive decline. They scored perfectly on the MoCA.
How is that biologically possible? If their brain is full of toxic plaques, why aren't they losing their memory?
Because of a phenomenon called cognitive reserve. Think of the brain's neural network like a massive highway system in a major city. The amyloid plaques act like roadblocks, destroying specific bridges and pathways.
Okay.
In a brain with low cognitive reserve, when a bridge collapses, traffic stops, memory fails. But a brain with high cognitive reserve, built through years of intense education, bilingualism, complex social engagement, and neuroplasticity, has built thousands of alternate side streets and detours.
So it just routes around the damage.
When a plaque destroys a bridge, the brain seamlessly reroutes the signal through a different pathway. The person remains functionally completely intact despite profound biological damage.
So if having the plaques doesn't guarantee you will actually get the clinical symptoms, then screening asymptomatic healthy people for these plaques sounds like a complete recipe for disaster.
It is a recipe for massive overdiagnosis and fatalistic anxiety. Imagine you are a healthy, vibrant 65-year-old. You take a cognitive test, you pass with flying colors.
But you get anxious about the future.
So you decide to pay for an amyloid PE scan just to know. The scan shows high levels of amyloid burden. You are formally labeled by the medical system as having preclinical Alzheimer's. How does that biological information change your life?
It destroys it.
Exactly. You might stop planning for the future. You might suffer from severe depression, which ironically damages the brain further.
And your family starts treating you differently.
Your spouse might start treating you differently, anticipating a devastating decline that, because of your cognitive reserve, may literally never arrive.
And do we even have a cure?
In 2026, while we have some new, modestly effective monoclonal antibodies that clear amyloid, they come with severe risks of brain swelling and bleeding, and we do not have a definitive, harmless preventative cure that justifies finding this pathology decades in advance in an asymptomatic person.
So the gap between biological markers and actual clinical symptoms is vast.
Incredibly vast.
Which brings us to the absolute bleeding edge, the most heavily debated tool in the neurology clinic today, Alzheimer's blood tests. Because just like the MCEDs for cancer, the biotech world has cracked the code on finding these microscopic brain proteins floating in the bloodstream.
Yes, they have. The advent of blood biomarkers for Alzheimer's specifically tests looking at the ratio of beta amyloid to a protein called phosphorylated tau, like the pTau217 test, is a monumental scientific achievement.
Explain what tau is, because we talk about amyloid plaques, but tau is the other half of the Alzheimer's equation.
Yes. If amyloid plaques are the garbage piling up outside the neurons, tau tangles are the collapse of the structure inside the neuron.
Oh, I see.
Normally, tau is a helpful protein that acts like the railroad ties holding the neuron's transport tracks, its microtubules, together. But in Alzheimer's, tau becomes hyperphosphorylated. It gains too many chemical phosphate groups.
And what happens then?
It detaches from the tracks, the transport system collapses, and the tau proteins twist into neurofibrillary tangles. The neuron effectively chokes to death from the inside.
And now we can detect that exact choking process from a blood draw.
Yes. For decades, the only way to know if someone was developing these tangles or plaques was a $5,000 PT scan or a highly invasive lumbar puncture, a spinal tap to measure cerebrospinal fluid.
Ouch.
Now, highly sensitive mass spectrometry can detect the minute signatures of pTau217 that have crossed the blood-brain barrier into the peripheral bloodstream. It is incredibly promising for research.
Because it's cheaper and faster.
It accelerates clinical trials by allowing scientists to easily and cheaply identify candidates who actually have the biological pathology.
But the reality of using this in the clinic for everyday people worried about their memory is a completely different story.
Entirely different. These highly accurate blood tests are not a standalone replacement for a clinical diagnosis. Remember, our fundamental rule of dementia is a decline in network function, and it cannot be diagnosed by a single molecular test.
Let's look at a complex real-world scenario. Let's take an older adult, a 72-year-old man named Robert.
Okay, Rob?
Robert has been noticing some worrying memory lapses over the last few months. He forgot his granddaughter's name for a fleeting second. He got turned around driving home from a grocery store he's visited for 20 years, and he's feeling deeply lethargic.
Which is very scary.
He is terrified. He reads a headline about these new 95% accurate Alzheimer's blood tests and begs his primary care doctor to order one.
The intuition trap rears its head again.
I want to know if it's Alzheimer's. Just give me the blood test. It's 95% accurate.
Right. But here's why comprehensive medical context is paramount and why doctors must resist just running the test. Are Robert's memory lapses due to the biological onset of Alzheimer's? Maybe.
But it could be something else.
But they could also be due to severe undiagnosed sleep apnea, causing chronic intermittent hypoxia, lack of oxygen to the brain, and severe sleep deprivation.
Which destroys short-term memory.
Exactly. Or the memory loss could be a pharmacological side effect of an anticholinergic blood pressure or allergy medication he just started taking.
Oh, wow.
It could be due to a highly treatable vitamin B12 deficiency. B12 is essential for maintaining the myelin sheath that insulates nerves. Without it, nerve signaling slows down dramatically, mimicking dementia.
Or what about infections?
Or, very commonly in the elderly, it could be an undiagnosed urinary tract infection. A UPI can cause systemic inflammation where cytokines cross the blood-brain barrier, triggering acute delirium and profound memory confusion.
Or depression. I've read that depression in older adults can look so much like Alzheimer's that doctors have a specific name for it.
Yes, we call it pseudodementia. The psychomotor retardation and apathy of severe depression completely blunt a patient's cognitive output.
Now imagine if the doctor ignores all of that clinical context and just runs the highly sensitive pTau217 Alzheimer's blood test.
Right. At 72, Robert naturally has some age-related amyloid and tau in his brain, even if he has the cognitive reserve to handle it. The blood test comes back positive for Alzheimer's pathology.
Oh, wow. So they label him with Alzheimer's, they hand him a terminal diagnosis.
Yes. They anchor on the molecular blood result and miss the vitamin B12 deficiency or the UTI entirely.
That's awful.
They tell him to get his affairs in order when in reality, a simple course of antibiotics or a B12 injection could have completely restored his memory and functional independence in a matter of days.
That is terrifying. The precision of the blood test actually blinded the doctor to the real treatable problem.
Exactly. This is why functional decline, family observations, and a comprehensive clinical workup matter infinitely more than a single biomarker score.
The context is everything.
A doctor needs to interview Robert's wife. Is he struggling to manage his finances? Is his personality changing? The Alzheimer's blood test is merely one piece of a very complex puzzle.
It's not a shortcut.
It is meant to be used after a rigorous clinical evaluation confirms that there is genuine progressive cognitive decline that is not explained by B12, thyroid issues, or medication.
Only then do you use the biomarker test.
Yes, to help determine if Alzheimer's pathology is the underlying cause of that specific, confirmed functional decline. It is absolutely not meant to be used as a screening tool for someone who just misplaced their reading glasses.
We really need to hammer this home for the listener to clarify these massive misconceptions, because the media portrays a positive genetic marker, like APOE4, or a positive blood biomarker, like pTau217, as a guaranteed, inescapable life sentence of cognitive decline.
Yes, they do.
But what you are saying is that molecular biology is not always destiny.
Biology is absolutely not destiny. A positive screening result for a genetic marker or a circulating biomarker simply indicates the presence of a protein or an elevated statistical risk factor on a population level.
It doesn't mean you're definitely getting sick.
It does not dictate how your unique, incredibly complex brain will compensate. It does not account for your cognitive reserve, your lifetime of learning, your cardiovascular health, the integrity of your blood-brain barrier, or your social engagement.
All of which really matter.
All of which profoundly mechanically impact whether you ever develop clinical symptoms. A positive biomarker test is a molecular data point. It is not a crystal ball.
Which brings us to the ultimate practical takeaway from this massive investigation. What we've learned today is that effective medical screening is not about blindly testing for every conceivable disease out of generalized fear.
Exactly.
It's not about letting anxiety drive your physiological decisions, and it's certainly not about buying direct-to-consumer molecular panels online just because an algorithm promises you peace of mind.
Peace of mind is rarely what they deliver.
Effective screening is a highly individualized, mathematically rigorous calculation. It involves a very sober look at your age, your specific lifestyle risks, your inherited genetic family history, any actual physical symptoms you are experiencing, and most importantly, the hard clinical evidence of whether the test actually improves survival outcomes without subjecting you to the devastating cascade of overdiagnosis.
If we connect this to the bigger picture, my final thought for you, the listener, is this. The decision to undergo a screening test should always prompt a deep, extensive conversation with a qualified healthcare professional.
Don't just do it alone.
Do not order direct-to-consumer tests in a vacuum. Sit down with a doctor who understands your specific biology and have them navigate the nuanced math of Bayes' theorem, false positives, false negatives, and the biology of turtles tailored specifically to your life and your risk profile.
That's incredible advice.
Medicine, at its best, is a human partnership evaluating data. It is not a blind algorithmic sweep.
I couldn't agree more. We started this deep dive talking about the expectation of precision, the comfort of that binary broken or not broken X-ray. But as we've seen, the landscape of early detection is murky, filled with turtles, false reassurances, and molecular ghosts.
It's a complicated frontier.
It really is. And I want to leave you with a provocative thought to mull over. As our technology gets exponentially better, as we enter an era where a single vial of blood can sequence the DNA fragments of microscopic cellular anomalies decades before they show a single physical symptom, we have to ask ourselves a profound, almost existential question. If our machines become so sensitive that they can find the trace molecular markers of future illness inside every single one of us, how will 2026 and beyond redefine what it actually means to be healthy?
That is the question.
If we all have mutated DNA and misfolded proteins lurking in our bloodstream, are any of us actually healthy anymore? Or are we all just pre-patients waiting for an algorithm to diagnose us? It's something to think about the next time you see an ad promising to show you everything hiding inside you. Thanks for joining us on this deep dive.